This is a program about the launch of a new risk prediction algorithm and guideline, which in Australia, and one of which, of course, is the most contemporary available in the world right now. Welcome to all of you attendees. We've got 2,700 people that have registered for today's meeting, and I'd like to begin by acknowledging the traditional owners and custodians of country throughout Australia and indeed throughout the world, and their continuing connection to land, waters and the community. We pay our respects to them and their cultures and elders past, present and future. I'd like to make a special welcome to those registrants outside Australia and those and to our panellists, Professor Mark Nelson, Professor Emily Banks, Professor Clara Chow and Professor Nigel Stocks. We will be finishing on the dot of the hour. That's because of a very important soccer match we have coming up, which will be of greatest interest to our Australian and UK residents. We have one international speaker tonight. That's me. I'm Garry Jennings, and I'm presently in London speaking to you. And we look forward to your participation towards the end through the Q&A box where you can submit your questions. We probably won't have time for them all, but we'll deal with them what we can. So let's have a quick run through about what this guideline is about. It depends on the fact that cardiovascular risk doesn't necessarily depend on just one risk factor. It often depends on the combined effects of many risk factors. And a better risk prediction modality will better predict risk. That'll get us focusing on the right people, giving them the right therapies and help with previously unexplained events, we hope. We've been using in Australia a 2012 instrument, which is based on Framingham technology, which of course is some 60 or so years old. And it only has a very small number of risk variables in it. And like all existing algorithms, it tends to overestimate the risk in low-risk populations and underestimate the risk in high-risk groups. And of course, in the last few decades, the prevalence of cardiovascular disease has fallen, particularly in Australia and most other high-income countries, although we're seeing signs of a plateauing of that in the last couple of years, perhaps related to COVID, perhaps related to other factors. So this was a process of trying to develop an accurate, low-tech way of clarifying high-risk individuals before they get it and doing something based on a guideline which is relevant to the population of Australia in particular, and that works for general practice. And then we wanted to make sure we've got the right strategies for those people. And we wanted an approach that's scalable across the population. Next one, please. So this is the first one to account for the traditional risk factors, high blood pressure, cholesterol, etc., but also social disadvantage, diabetes and kidney-specific risk factors. There are more variables. There's the additional option of reclassifying people after they've been through the calculation to enable and support clinical judgment, which is always key to proper assessment of risk and management. It does consider some new and emerging imaging techniques and novel biomarkers and risk factors for heart disease, and it gives very specific and individualised advice for First Nations people. Indeed, there's a First Nations and a consumer overlay across every recommendation, every consideration in this guideline, which has been approved by and endorsed by the Royal Australian College of General Practitioners. Thank you. Next slide, please. Okay, so the process, there are two sides to this slide. One is guideline development, which used a very rigorous standard. The process was absolutely meticulous. We had 9 expert advisory groups, all multidisciplinary, all sorts of skills involved, as well as I said, that consumer and First Nations overlay. It was based on an independent evidence review with 33 PICO questions, which are always the beginning of a new guideline, and that was done by the Sachs Institute and Bond University. And then we used the grade system, which is the internationally recognised standard for grading recommendations. The calculator itself was based on assessment of all of the calculators around the world, and there are many, and again a rigorous process for evaluating those. And it so happened that the New Zealand Predict population and equation fitted our criteria the best. But it did need to be recalibrated to the Australian community, because CVD death rates are a little different, only a little different, but that recalibration makes it very appropriate to the population where it'll mostly being used. And then we had advice to guide the risk treatment thresholds, which once again were based on a systematic review. And I've talked already, and you'll hear from Professor Chan a little bit later about the reclassification factors. Next slide, please. I talked about those 9 committees. It's small writing, you probably can't see them, but it's important that you recognise that this project was developed by the Heart Foundation on behalf of the Chronic Disease Prevention Alliance and our friends and colleagues in the Stroke Foundation, Kidney Health Australia, Diabetes Australia, and as I mentioned, it was endorsed by the RACGP and funded by the Australian government. A really strong part of this process was over 200,000 health professionals and agencies and stakeholder groups were consulted and had the opportunity to provide input into the process. So this was a very rigorous process. It was a highly consultative process, and one which I think we're very pleased with the outcome. Next slide, please. And you can go through these very quickly for now, and please, Beck, because there are really 5 stages to this guideline for those of you that had a look at it. The first one is to identify the right people that it's appropriate for, and they're people without cardiovascular disease and people who aren't already at high risk. You then apply the calculator, and there's a list of variables on this, which many of which are optional, some of which are necessary to come out with a risk category, which is either high, low or medium. Those thresholds are a little different to the previous guideline, because low is less than 5%, 5-year risk, medium 5 to 10, and high 10 to 15. And then the reclassification factors, and then a very strong emphasis on turning the computer screen around and talking to the person in front of you, communicating that risk in a way that can be understood, and then leading to agreed management programs. Next slide, please. This is how it looks in practice. This is the actual screen for those of you who haven't looked at it. That's the stage. Stage 1, identifying the right people. Next slide, please. Stage 2, putting the variables in for the calculation, and there are the optional variables on the right, including those specific to diabetes, because it's very clear from the predict population, a very large population in New Zealand, that not all diabetes sufferers are at high risk of cardiovascular disease. There's a spectrum, and you can be more sensitive in predicting risk in people with diabetes in that case. Next slide, please. Then the risk categories which come out, which I've already described to you. Next slide, and the reclassification factors which are on the right there, which can be considered, which you'll hear about in some detail. And this is the presentation of the risk, either as a kind of speedo dial along the bottom, or as icons on the right, in which you can then play around and talk to the person that you're dealing with about what might happen to that risk if you, say, reduced your cholesterol, reduced your blood pressure, or something else, stopped smoking, for example. Next slide, please. And this is the very general recommendations about management, which are also in the guideline. Next one. People will often ask, I know that a certain risk factor is very important for cardiovascular disease. Why isn't it in the calculator? Why isn't it in the guideline? It's usually in the guideline, but there are good reasons why it mightn't be in the calculator. And they're largely based on lack of evidence. It might be related to risk, but it doesn't contribute above the existing variables in the equation. That is, the equation's got what we call beta coefficients, and that number is near 1. So there's no point in adding it and then multiplying something by 1. It might be that we don't have sufficient data from the cohort that we're using to base this equation on. It might be that we will have soon, and hopefully we'll be able to modify this in time. It might be it didn't stand up to the independent evidence review. People thought it was important, but the data or insufficient or conflicting, and which can't just drop coefficients in from elsewhere, or there are things that are out of scope. This was a particular guideline had headlines in which we thought were too far for us to go in making general recommendations for the population. So in fact, guidelines don't start with the left of these bubbles down the bottom. What I think, they start on the right with the PICO questions and then the evidence base, and then we try and reconcile that with what the expert opinion is and what others think, and that's the product that you'll be seeing online on cdbrisk.org.au. Next slide, please. And there are lots of supporting resources available through the Heart Foundation website. And I think that's the end of my slide. And we'll move on now, if we could have the next slide, please, to the next part of our presentation tonight. And that's, how did we recalibrate the predict equation for the Australian population? Why did we select the equation that we have? And how does it work? And there's no one better to do that for you than Emily Banks, who chaired our algorithm expert advisory committee, a very distinguished international committee, and she's going to take you through that. Next slide, please.
Thanks so much, Garry. And I too would like to acknowledge the traditional custodians of the land that I'm on, the Ngunnawal and the Ngambri people. I'd like to pay my respects to elders past and present, and to any First Nations people joining us today. I'd also like to acknowledge the huge amount of work that has gone into these guidelines. We on the panel get to front up and talk to you about it. But there's been a massive amount of work in the background. I'd also like to acknowledge the soccer match that's about to happen, and to express my best wishes to both sides. I'm wearing the Matilda's colours here, but I'm sure you've all got different teams you're supporting. So the first question we looked at was, why replace Framingham? Actually, we didn't start off saying we definitely have to replace Framingham. Framingham was one of the equations that we considered alongside others, but we knew that it needed to be reviewed because the Framingham risk equation was developed in a predominantly white US cohort, a small town in Massachusetts, and it was collected in the 60s and to the 80s. We know that cardiovascular disease event rates have changed a lot since then, and the whole point of an equation is to actually take a person's risk factors and say, what is the likelihood this person will have a cardiovascular event? So you need really good data that are grounded in the current CVD incidence or the CVD event rates. We know that Framingham overestimates the risks for the general Australian population because we've had such success at controlling cardiovascular disease. Obviously, there's a long way to go, but we've had an 80% drop since the 1960s. We also had to look at other equations because we don't currently have an Australian contemporary linked data set that would allow us to produce our own equation. That's something we're working on. So what we had to do was to evaluate existing risk equations that were recommended by current guidelines to identify one that is best suited to the Australian context. And then we had to recalibrate it to make sure that we were really aligned with Australian event rates. Next slide, please. So really, when we were looking at the overall process for developing this CVD risk calculator, we knew we had to review whether Framingham was right. But then we had to say, well, how are we going to do that? We essentially created criteria to look at how we were going to choose our risk equation. We needed to generate the data to recalibrate that equation. We then had to recalibrate the equation. And we also had to look at how we were going to get appropriate risk treatment thresholds once we had the equation. We then also looked at applying risk reclassification factors and patient decision support tools into that user experience. We were ably guided by our algorithm expert subgroup, and I really want to pay tribute to the national committee we had there, and the people are listed there: Rod Jackson, Ellie Page, Anushka Patel and Mark Woodward. We also had a working group of people from the Australian National University, and those people are listed there, particularly ably led by Ellie Page, providing the background information and data and essentially the maths that goes on behind the calculator. Next slide, please. So in terms of selecting our CVD risk prediction equation, we actually had criteria that we had devised a priori in order to select the most appropriate equation. So we didn't start off with a preconceived idea about which one it would be. We then reviewed the existing international equations, and we only looked at ones that had been used by major international guidelines. So if you click again the slide, we'll have the list of selection criteria. And really, we had to have a guideline that used contemporary data that had appropriately established CVD risk factors in it. There was an a priori wanting to have measures of ethnicity and social deprivation to improve health equity. And also we wanted to make sure that the outcome was a broad range of CVD events and deaths. We wanted to make sure that the equation was representative of a general population, particularly the primary care population. We wanted excellent model performance, and we wanted to have external validation, particularly in an Australian population. And we also needed to be able to actually look under the hood and recalibrate and modify the equation so it could be used appropriately for the Australian population. Next slide. So when we looked at all of the different equations, and this is in a recently published MJA paper, if we click again, you'll see that there were really only 2 equations that fitted almost all of the criteria. And predict, so it was Q risk 2 or 3, which is a UK equation, and predict. And predict was the only one of those 2 where we could actually recalibrate it and make it appropriate to the Australian population. So that was how predict was chosen. Next slide, please. We also needed to then recalibrate the risk prediction equation and modify it. Now, we usually want to look at the risk factor distribution and the CVD event rates from the target population. We didn't have a suitable primary care data set to generate those, so we had a pragmatic workaround, which was actually to align the CVD risks predicted by the equation to event rates observed in Australia. And we compared event rates for different age and sex groups based on mortality in Australia and New Zealand. So that sort of gave us an indication of how much more common or less common the CVD events were in those groups, so we could either adjust them up or down based on that. Next slide, please. So when we looked at that, and what we can see here is in the yellow, we've got the males, and so the lighter colour is the males, the darker colour is females, the yellow colour is Australian, and the grey and black are the New Zealand data. And you can see there that the age-specific rates are pretty similar between the New Zealand and Australian people in the 45 to 54-year-old age group. We did have some more differences observed at the younger age groups and at the older age groups. So we ended up with these risk multipliers, which is for the incidence that we get for women aged 30 to 44 in New Zealand, to get the Australian rate, we'd have to multiply it by 1.3. So those, you don't really need to know about this as users, but this is what's going on in the background. Next slide, please. We also then had to look at what was happening for Aboriginal and Torres Strait Islander people. And what we found was that for most, can we go backwards, please? For most age groups, it was similar, but there were larger differences in the younger age groups. So if you look at the 45 to 54 group, there were quite big differences between Aboriginal and Torres Strait Islander men and Maori men. And at older age groups, the situation was reversed, that Aboriginal people had lower death rates than Maori people. So this meant that there were quite a number of uncertainties about using Aboriginal and Torres Strait Islander data and Maori data as trying to compare those. And that fed into the decisions by the Aboriginal and Torres Strait Islander representative, well, the expert group, to say that we would create a reclassification variable regarding Aboriginal and Torres Strait Islander status. Next slide, please. So what we then also did was, because Maori and Pacific Islander people are quite a substantial proportion of the New Zealand population, we reran predict without those groups in, and we extended the age group to 79. We also removed family history, ethnicity, and BMI as variables. Family history and ethnicity are considered as reclassification variables. And the main reason for that was, in the equation of predict, family history had very little impact. So if we'd kept it in the formula, family history would not have really had a big impact on people's risk scores. And there was a view of the expert group that we needed to have people able to be upgraded or downgraded, particularly upgraded based on a strong family history. There was a lot of uncertainty about ethnicity as well. Could we go back one? Just let me check that okay. Then we also included the index of relative socioeconomic disadvantage based on postcode instead of the New Zealand deprivation score. Next slide, please. And then we also used systematic review evidence to guide risk treatment thresholds. And we found that a 10% risk treatment threshold was actually pretty much in keeping with the data about the number needed to treat. Next slide. We also found the same for lipid lowering studies, but that the risk benefit equation became less favourable at much lower levels of risk, particularly 5% 5-year risk. Next slide. So then in terms of treatment thresholds, we looked at a wide range of data on this. There was actually quite limited data, but what we did end up knowing is that because Framingham had overestimated risk, we needed to lower those thresholds to even be broadly similar to what we had originally done with Framingham, but also to be consistent with international guidelines. Next click. Yep. So the high risk threshold has decreased from, well, it was a nominal 5-year risk of greater than 15%, but actually changing it to 10% is just really respecting the differences between the equations, but also align more closely with international guidelines. There's an intermediate risk, which is 5 to 10%, and that's where you would consider blood pressure and lipid lowering pharmacotherapy, depending on clinical context. Next slide. So if we're actually looking at broadly how these things apply, if we bring it together for test cases, our first patient is 56 years old. She's never smoked, no history of diabetes or atrial fibrillation. She lives in an area rated as C for 5. And you can see her results there for total cholesterol to HDL and systolic blood pressure. She's not on any preventive medications. So if you imagine her CVD risk is, from the equation, is 1.4% over the next 5 years. Her risk calibration for that age and sex group is 1. So her ultimate risk rating is 1.4%. Next, please. Patient B is 65, has diabetes, and you can see all of his measures there. His CVD risk by the calculator is 1.29, but he's in the age group where New Zealand overestimated it slightly compared to Australia. And so his ultimate ranking is 9%. And patient C, next click please, is 62, has diabetes, non-smoker, but if you look at all of his risk factors put together, his 5-year CVD risk is 15%, multiplied by 0.9, so he's in the high risk group, which is 13.8% there. Next slide, please. So that's really summing it up. I'm going to hand back to Garry now.
We'll keep on moving. Thank you very much, Emily, because we've talked a lot about reclassification factors, and Professor Clara Chow chaired that very important group which looked at new and emerging risk factors and also things that weren't perhaps suitable for inclusion in the calculator itself, but important for people to use their clinical judgment. So over to you, Clara.
Thanks, Garry. It also gives me great pleasure to present this on behalf of many, many people that contributed to this. And I also would like to acknowledge the traditional owners of the land, the Darug people. Okay, so I'm going to look at how we apply this in step 2 and step 3. And we'll go fairly quickly through this. So we've already touched on this. So the new calculator now has some new variables, particularly the cardiovascular disease medicine variables, blood pressure lowering, lipid lowering, and antithrombotics. It has some optional variables, postcode as a marker of socioeconomic status, history of AF, and for people with diabetes, a number of new factors. It is important, of course, to note that if they've got a clinically determined high risk, they shouldn't be using the calculator, or those are people with moderate to severe CKD or FH. So the calculator will then spit out a risk assessment of 5 low or intermediate or high risk, and then will prompt you to consider optional reclassification factors. And these are here, and I'll go through these in the following slides. The concept of risk enhancing factors has actually been embraced by a number of international guidelines. Probably the first of those guidelines was the American College of Cardiology, AHA, prevention guidelines. Generally, they're supporting identification of those who may be at greater risk for cardiovascular disease than suggested just by the risk equation. And so the new Australian Cardiovascular Disease Risk Guidelines introduces the concept of reclassification factors, which are to be applied after the risk is calculated with the equation. So hopefully with these factors, you can have a more individualized risk assessment and a personalized risk discussion with the patient. So these are the 5 reclassification factors: ethnicity, family history of premature cardiovascular disease, chronic kidney disease, severe mental illness, and a coronary artery calcium score. As you can see, 3 of these suggest you reclassify upwards, and 2 of these, there's an option to either reclassify up or reclassify down. Family history, for the purpose of this guidelines, was defined as those with a first-degree relative, female relative aged less than 65, or first-degree male relative less than 55 years. And severe mental illness is defined in a fairly practical manner as a current or recent mental health condition requiring specialist treatment, whether received or not, in the last 5 years. So as I said, the point where one considers this is after the equation is applied. And they're probably most relevant to people that fall at a borderline between risk categories, for example, 4% here. So with respect to ethnicity, the 3 points are: for First Nations people, consider reclassifying estimated cardiovascular disease risk up a category. In people whose estimated cardiovascular disease risk is close to the threshold for a higher risk category, consider reclassifying risk again up for Maori people, Pacific Island people, or people of South Asian ethnicity. But for people who are of Chinese, Japanese, Korean, Taiwanese, East Asian ethnicity, consider reclassifying down. Now, you'll note the very careful wording of both of these is close to the threshold. Consider reclassification up or down. This evidence, or these guidance, are based on this systematic review, and I might not go through this in detail, but just to indicate for both women and men, these ethnicities suggested a higher hazard or higher risk, and Chinese or other Asians a lower risk. Family history. For people with a family history of premature cardiovascular disease, consider reclassifying estimated cardiovascular risk to a higher risk category. So again, this is based on PREDICT, and it could have been potentially dropped straight into the calculator, but it was recognised that family history is poorly recorded often by individuals and can be poorly documented in primary care records. But when people do know that they have a family history of premature coronary disease, it is a strong and important risk predictor, and therefore it was considered better placed as a reclassification factor than a compulsory factor in the equation. Chronic kidney disease, noting that if people have moderate to severe chronic kidney disease, they actually should be identified as clinically determined high risk, and hence the calculator shouldn't be used. But for people who do not have diabetes and have a sustained EGFR that is between 45 to 59 mils per minute, etc., or persistent UACR 2.5 to 25 for men, or 3.5 to 35 for women, then strongly consider reclassifying that estimated cardiovascular disease risk up a category. For severe mental illness, I mentioned this definition before, but it is also recognised that for people living with severe mental illness, consider reclassifying estimated cardiovascular disease risk to a higher risk category, particularly if the risk score is near a risk threshold. So I'll also note the treatment with second generation antipsychotic agents is associated with a 29% increased cardiovascular disease risk in women and 14% increased cardiovascular disease in risk in men, and this is noted in the guidelines. Coronary artery calcium score, also for the first time, this is incorporated directly into the cardiovascular risk guidelines, but it is important to note that it is not recommended for everybody. Hence, the first recommendation is that it's not recommended for generalized population screening for cardiovascular disease risk. However, it is considered a reclassification factor. Again, another important note that it should not be considered in a person who has a history of myocardial infarction, as they already are at high risk, or a person who is already at high CVD risk by the calculator, because treatment is indicated in these groups regardless of calcium score. Where it can be useful is in reclassifying risk levels due to calcium score when treatment decisions are uncertain. So for example, in people at low to intermediate risk, or perhaps it can be useful to inform discussions between the practitioner and the person about modifying therapy. And the two sort of categories of importance are a calcium score of 0 that could reclassify a person to a lower cardiovascular disease risk category, or a calcium score of 99 or greater than the 75th percentile for age and sex. I won't go through this. This mainly summarizes what I've spoken to. And I'm not going to go through this in a great deal of detail either, but just to say that the mean discrimination with, of adding calcium score to the risk equation is fairly small. It's pretty small, as you can see, 0.036 of the overall AUC. But calcium scores do have a very strong negative predictive value. The final slide I've got here is to talk to the other risk factors considered in the guidelines. And as Garry pointed out, there are many other risk factors. The guideline does try to note a few of them. The ones up here in the box are the ones that systematic reviews were done with specifically to inform the guidelines. That's ankle brachial index, high sensitivity C, reactive protein, and rheumatoid arthritis. And in quick summary, really they showed no additional discrimination value beyond the cardiovascular risk calculation, should not be routinely assessed in cardiovascular risk assessment. The guidelines also make some important comments with respect to these 4 things. It encourages people to take a pregnancy history, including a history of premature or early menopause in women, and encourage people to do cardiovascular disease risk screening earlier in the people that are positive for a history of these things. It does talk to lipoprotein A, again, not recommending routinely for all, but indicating that there is evidence that it may be important in certain subgroups to classify risk. It does talk to polygenic risk scores, again, recognizing that in people with high risk scores, it is clearly predictive of outcome, but also acknowledging that there are many polygenic risk scores and we don't have enough information at this current time to bring together all of this evidence and to really work out who will best benefit from polygenic risk scores. And it also makes comment with respect to COVID-19 infection, recognizing the COVID-19 infection does identify people that are at higher risk. And thank you.
Thank you very much, Clara. And we're running a little bit behind, but this is a guideline by GPs for GPs, I often say, and it's great to have Nigel Stocks here, who's again one of our chairs of the expert committee, to talk about risk communication and management. Thank you very much, Nigel.
Sorry, I'm trying to share the screen. Yes, it's coming up now.
I'm sorry to rush you, Nigel.
Nigel, that's fine. Okay.
My fault.
I finally got full screen. Thank you very much. Look, I'm going to do the final two boxes, the 4 and 5 of communicate CVD risk and manage CVD risk. The other speakers have already touched upon all the other beginning areas of the CVD risk assessment. What are the principles behind this? Sorry, I'll just go up. Okay. Sorry, I'm having a bit of trouble here. Now, so risk assessment, we're going to target pharmacotherapy to those who will benefit most. And these are people who are at high risk. This is an obvious statement to make, but it's also important to not over-medicalize or over-treat people who are considered low risk. But the guidelines address, in a lot of cases, or in all cases, lifestyle factors, irrespective of the level of risk. And this has to be done in collaboration with the patient and finding what motivates the patient. And of course, the audiences are all GPs, and all of us have experience with doing this in our practice day to day, not only for cardiovascular risk, but other conditions as well. The setting of targets obviously is an interesting point. Some patients are very well motivated by having a target, whether it's a blood pressure target or a cholesterol target, or for that matter, exercise or other aspects of care and lifestyle. But others perhaps are sometimes demotivated by the fact that they can't achieve that. And I think the most important thing to remember is that any reduction in risk is a benefit to the patient. So it's really what is achievable and practical for them. And it's across these areas like quit smoking, healthy eating, regular exercise, healthy weight, limiting alcohol, and obviously blood pressure and lipid lowering, because those are the primary ways that we can actually affect change for those individual patients. So I'll just quickly say, in terms of, you should look at the grade recommendations that are in the guidelines, because you may get confused by the strength and certainty of evidence, but please read them and be aware that they are important guides for how strongly you are going to push these elements of various preventive healthcare activities. We know that communicating risk is very important. And in the past, we used to have laminated charts for cardiovascular risk. But now we have the online version, and I recommend it to you all that, having entered the cardiovascular risk factors into the equation, you will then come up with a very nice diagram which can then be shown to the patient, and it can actually be used then in addition to show how changes in risk factors can affect their overall cardiovascular risk. We've already gone through this table previously, but I'll just reiterate that those people in the low risk category, really all you're doing is supporting and advising a healthy lifestyle. Pharmacotherapy is not routinely recommended. In the high risk category, we recommend prescribing blood pressure lowering and lipid modifying pharmacotherapy in addition to the healthy lifestyle changes. It's the intermediate risk, the 5 to less than 10%, that you're going to have to nuance what you do depending on what the patient wants and what you think is in their best interests. So, and of course, you've already applied the reclassification elements as well. We also have to be aware that in the high risk category, we don't have to formally reassess CVD risk. It's generally not required, whereas we want to assess in those patients who are at low risk, their risk every 5 years. Now, these are obviously things that are important that you know and that we try, sometimes successfully, sometimes not. But we felt that the smoking cessation, that there was a strong recommendation that we get this occurring within our practice. Alcohol reduction is going to be a bit of a trickier area because of the recent changes that have brought the levels down to 10 units of alcohol per week and no more than 4 on one occasion, because I'm sure that a number of our drinkers in our patient population are probably exceeding those limits, even if they're not aware of it at this particular point in time. But if you can make a reduction, that'd be would be a very good thing. We have to think about nutrition, and obviously we can talk about the healthy food pyramid and eating all the right foods. But then we also considered, as part of the evidence for the guidelines, whether particular elements of dietary change would be helpful, such as reducing salt intake, using or applying a Mediterranean-style diet or a DASH diet in particular, or for that matter, eating oily fish. So consider those, and clearly it's going to be up to patient preference in a large extent. I know that we all have difficulty in motivating patients to undertake more physical activity and to achieve healthy weight. All we can do is continue to encourage and advise and use whatever means we can have available. System changes for the individual patients is probably a very good way of helping, such as even just getting off a bus a couple of stops before their final destination, so they get a few more steps in during the day. And of course, healthy weight is related to a healthy and nutritious diet. Pharmacotherapy probably will be the mainstay of reducing cardiovascular risk. And as I said before, the greater the risk, the greater the benefit for any reduction. So getting people onto statins and blood pressure medication is important. Our guidelines do not make recommendations about the type of medications you should use, and that is covered in other guidelines. We don't provide targets. Various papers and other guidelines do, but it really should be a shared discussion between the clinician and the patient. And look, thank you. I've rushed through it because I know everybody's anxious to get on, and we do have some Q&As as well. So I'll stop sharing.
Thank you very much, Nigel. And that last slide showed you some of the many, many people that contributed to developing this guideline, and we are so great team at the Heart Foundation, led by Natalie Ruffel, Lisa Kalman, Emily Bradbury, and others. So we're going to have some questions now. There've been quite a lot coming through, and thank you very much for that. I think the first one relates to individual risk factors like blood pressure and lipids, and perhaps I'll address this to Mark Nelson. To introduce Mark to you, he was my co-chair on the Guideline Advisory Committee, and a GP from Hobart and the University of Tasmania. So this specific question was, if someone's identified as low risk from the calculator, what if their blood pressure is very high? You still treat them, or what, Mark? How do you handle it?
Thanks, Gary. The recommendation you just saw on Nigel's, if they do have very high individual risk factors, then you manage those on the individual risk factors. So we do have blood pressures and cholesterol levels over which you would manage according to that individual risk factor. The general principle, though, is that risk factors tend to cluster. So you'll usually see mildly elevated blood pressure, mildly elevated cholesterol, etc. And you usually get a low risk score because of their age, because age is the most important determinant of risk. And as I explained to my patients, we need to do something about your blood pressure and cholesterol, because the only thing that's protecting you at the moment is your age. If you don't change your behaviors, you're going to eventually end up on medication. So I think it's an opportunity when you have high individual risk factors and low absolute risk to reinforce the lifestyle factors as ceasing smoking, getting regular exercise, or what I call the grandmotherly advice. And as GPs, we know that they have benefits above and beyond just CVD prevention, for example, cancer prevention. So I think it's a bit of a no-brainer. But there is the possibility, if the individual risk factor is very high, to treat on that alone. But the general principle is to treat on absolute risk.
Thanks, Mark. I've got a question which I think I'll answer. Why 5-year risk stratification instead of 10 years? As many of you know, a lot of the international guidelines present 10-year risk. This was something that came through, we've been using, of course, since the 2012 guideline in Australia and in New Zealand, and this came through very much from the consumers. They said that 10-year risk doesn't mean much to me. That's a long time on the, that's a bit on the never. 5-year would be really meaningful. And if you tell me I'm at high risk of something happening that soon, I will do something about it. So it was largely a consumer-driven decision. We've got lots of other questions. I'll get to as many as I can. Some for you, Emily. firstly, about BMI. Everybody understands that BMI is rampant in the community at high levels. It's generally associated with high risk in all of our minds. Why isn't it in the calculator?
So the calculator includes risk factors which are independently associated or predictive of the outcome of increased cardiovascular risk. And we know that BMI, people with a high BMI are at increased risk, but it's essentially mediated through the relationship of BMI to diabetes, to the relationship with high cholesterol, and to the relationship with, or dyslipidemia, and to the relationship with blood pressure. And what these equations have found is once you take those three factors into account, there's no additional value in having BMI there. So it's essentially really about getting those downstream predictors in there. And so it was not seen as necessary. And obviously we want to minimize the number of variables that the general practitioner or other health professional has to input.
So that leads to an interesting question. Is BMI something you might want to target though, as far as when it's high?
Absolutely, because it's an upstream predictor of those things. So if you can get someone to really substantially reduce their body mass index, it will have beneficial effects on diabetes management, but also their blood pressure and their cholesterol. So it's definitely something you want to target in management, but it isn't an independent predictor of outcomes once you've accounted for blood pressure, diabetes, and dyslipidemia.
Yeah, and look, there are a number of other questions like that about why things aren't in, and I just refer you back to that earlier slide on why variables aren't in, and there would always be a very good reason. And the prediction equation is quite agnostic as to what goes in and what goes out. It's a question of what the associations are. It doesn't tell you about causality, doesn't rank them apart from the coefficients that's associated with them. Another question while you've got the floor, Emily, and that is how much extra accuracy does the diabetes sub-equation provide?
So this is a major advance for us, and it does increase the accuracy, but you can still predict the risk of someone who has diabetes without using it. So it's a kind of added extra, and it does give you better resolution. It's certainly a big improvement on the last equation where we just said, for example, if someone's age 60 or over and has diabetes, they're automatically at high risk. People with diabetes, we now are able to give them a risk prediction. So it does increase the accuracy, but you can still use the equation without those additional risk factors for people who have diabetes.
Thank you. Perhaps Mark, we've got postcode as a measure of socioeconomic status, but we know that there's quite a bit of diversity within any given postcode. How does the guideline cope with that?
Yeah, so postcode is a good surrogate measure for SES, but obviously we know that there are homeless people who live in Toorak, and there are people who live in mansions in poor economic areas. And this is where the GP's or other person's knowledge of their patient stroke client will allow them, once you've typed it into the calculator, you're given a risk, but there's a sliding scale below, so you can adjust their SES according to your knowledge of the patient, whether they're somebody who lives in a McMansion in a poor area or, visits you off the street. Thank
you. Nigel, I only ever meet people at social occasions who've got a calcium score of 0 or hundreds and were saved by some sort of intervention. But can we really trust a calcium score of 0 if someone, if say lipids are high, LDLs in the 5 to 6 range?
Yeah, look, I think Clara covered that quite well in her presentation. But just to reiterate, if somebody has a coronary artery calcium score, that of 0, it means that you can actually reclassify them down potentially if they're in an intermediate category or even a high risk category to some extent. But then you have to really balance that. And equally, if somebody has a score of 99 or above, you may want to reclassify them up. Because it's important to recognize that this may, despite the fact that, Clara was showing that, it's not necessarily a great predictor, it can actually be some way helpful in determining for an individual whether they should be on some sort of lipid lowering or antihypertensive. I guess also we have to say that if you do have a zero score, that in the next 4 or 5 years, it may not be zero, and there is a potential there to potentially, if they can afford it, if they have the means to maybe have it repeated, because it may no longer be zero, and therefore, along with other risk factors that may have developed, they may then fit into a category that does need some sort of pharmacotherapy.
Yes, we did consider the equity issues in making these recommendations, but they are, of course, important given that there is no MBSI item for this particular test. Clara, do you want to add anything?
Yeah, I just thought I might add, I think that some of the questions were also pertaining to if they have a very high single risk factor score. So for example, if they had a calcium score of 0 and maybe a LDL of 5 or 6. I mean, firstly, if they have an LDL of 5 or 6, one should think about FH and go through the assessment as to whether they do or don't have FH, because that is a high LDL. I think that people feel uncomfortable not treating a high LDL, and certainly you should be treating it with, considering lifestyle and other sort of modifications. But, you might have a little bit more time maybe up your sleeve with respect to not starting them on statins if their calcium score is 0. But just thought I'd add that. I think it is harder. It is something to help guide the things, but it definitely isn't something to take away the ability to treat a single very high levels of risk factors.
Yes, it can be very useful used in the right people in the right way. It's not a get out of jail card, a calcium score of 0. We know that young people quite often have soft plaque without much calcium, but very useful if used properly. There's a couple of other questions which I might try and address. Because it's one thing to have a guideline, the main thing is to make sure it's implemented, and that's something that the Heart Foundation will be devoting a lot of attention to, and Natalie and her team will be developing a whole lot of educational materials, promotional materials. We'll be presenting it at various professional societies and meetings. And the other thing we want to do is make sure that next time we do this, we can use Australian data. And if we can collect data from the use of this guideline, and if it's used widely enough, and at the moment we know that risk checks aren't done as much as we would like, then we'll be in a much better position to monitor our own health system and what's happening. And the second question, a practical one, is when it'll be in our GP software. That's actually up to the GP software providers, and there are many of them. And we hope they're working on it right now, and we'll certainly make it as easy as possible we can for them. But it will be a few months before it pops up. So you will need to go to the website if you want to do that, and we know so many of you have. There's a question about aspirin, which is not dealt with, I don't think, in the guideline. When would you add that and is there evidence of benefit? Nigel, do you want to briefly talk to that?
Very quickly, as people may have realised, our guideline does not touch upon aspirin, and certainly we wouldn't be recommending the use of aspirin for the primary prevention of cardiovascular disease. Certainly it has a fundamental role in those people with established heart disease, but the weight of evidence is not such that we can actually start to recommend it for primary prevention.
A couple of
that's on risk on benefit, and that's on the basis of risk and benefit. And it's important to understand that sometimes there's marginal benefit, but there's actually additional risk, and that additional risk goes up as people get older. And so does the potential benefit, but the risk outweigh the benefits.
There are a number of questions about lipids. The actual equation has a ratio, which may not be familiar to you, but you are able to put in the individual levels of LDL and HDL. And whether fasting or non-fasting, the Australian Society of Chemical Pathologists says you don't need to do fasting lipids now. And certainly we want to be pragmatic with this equation. You use what you can get. Or what you've got, and you can refine that depending on the results that you get. I think we might wrap it up now, and I'll just hand over to Mark Nelson for some final remarks. Thank you very much, Mark. But my thanks too to everyone who's participated on both sides of this webinar.
Yeah, thanks, Garry. So these guidelines are replacing the 2012 guidelines, and the best evidence we have, only about a third of GPs use them regularly. I make a passionate plea that it should be the basis of primary prevention management in general practice. Modelling suggests that if all of us GPs swapped over from individual risk factor to an absolute risk estimation-based management of our patients, that we would have 20,000 fewer myocardial infarctions and strokes per annum. So just think on that. So we should be thinking on a population level as well as the individuals who sit in front of us. Is that a common theme has been concerns about thresholds. Rest assured that the thresholds, even though they look lower, because of the drift, as Garry mentioned earlier, in the background prevalence of cardiovascular disease in our community, we were grossly overestimating risk, so that even though the thresholds seem lower, the classification should classify a similar number of patients. And what I've been doing is dealing with my own patients as they come in and doing on both calculators, and finding consistently they give the same classification, even though the new calculator gives you a lower score. So if somebody's a low, mid, intermediate risk, they're on a low intermediate risk on both calculators. So you won't be, there's no creeping increasing treatment and pushing of drugs. We want to get drugs to the people who most need them. I think another thing that's very helpful in these guidelines is the increase in the age, because in primary care, we're dealing with an aging society, and a lot more of our patients are reaching 75 and above, still in a relatively healthy condition, living independently at home. And we know that having something like a stroke robs them of their independence and puts them into a nursing home. It doesn't kill them. The ratio is only 1 to 7. So we want better management of CVD risk factor in our aging population. We now go up to the age of 79. As Emily said, there is a specific risk that allows the subtleties. We know that as somebody gets older, their risk associated with later onset diabetes isn't the same as somebody who develops at 35, and that's why risk has gone down to younger age groups, because if you develop type 2 diabetes at a very young age, your lifetime risk of CVD is so much more. A bit of a last plea, as Garry said, this is based on the calculator's based on New Zealand. We would love to have an Australian calculator. So whatever we can agitate from primary care to be able to get a suitable Australian data set to inform us and do our own calculator, the better. I'd just like to lastly thank all of you. I don't know how many have turned up. I've certainly been answering a lot of questions, and they're really good questions in the Q&A session. I've been typing as fast as I can, but there's obviously a lot of you out there. So thank you very much for coming on. You'll be sent a copy of the recording over the next few weeks. We'd encourage you at the end of this session that there will be a survey available. It's only short, will take you a few minutes, and it will allow you to get a certificate of attendance, which you can use for RACGP or ACRIM, I'm sure for ACRIM as well, attendance. If you don't have time to do it, and I understand you may be all rushing off to your televisions, you can do it later. There's a possibility of completing that survey later. Again, I'd like to thank you all for attending, and for the people who organised the webinar on the evening. Oh, and I've just had a note, highest attendance rate ever for something that the Heart Foundation's done. So thank you all again. And thank you, Garry, for co-chairing, and other panel members.
Thank you.